Today's topic is Neurophysiology of LA at Dr. Anitha, Senior Lecturer in Neural and Maxillofacial Surgery. The function of a nerve is to carry missiles in the form of action potentials called impulses. A transient depolarization of the membrane due to brief increase in the permeability of the membrane to sodium and a delayed increase in its permeability to potassium is known as action potential. The impulses are initiated by chemical, thermal, mechanical, or electrical stimuli. Coming to electrophysiology of nerve conduction, resting potential is defined as the difference in voltage between the inside and outside of the cell as measured across the cell membrane. It is produced by differing concentration of ions on either side of the membrane. When the neuron is not being stimulated, it means a resting potential of about average minus 70 MV. The interior of a nerve is negative relative to the exterior. When a stimulus excites the nerve, it leads to initial phase of slow depolarization. Electrical potential within the nerve becomes slightly less negative. Failing, potential reaches a critical level, and then there is a rapid phase of depolarization results. This is threshold potential or firing threshold. The firing threshold is around minus 50 to minus 60 MV, which corresponds to slow depolarization, and the final threshold reached is the action potential, that is plus 40 M. The phase of rapid depolarization leads to reversal of the electrical potential across the nerve membrane. The interior of the nerve now electrically positive than exterior. A potential of plus 40 MV exists inside the nerve. After repolarization occurs. The electrical potential gradually becomes more negative inside the nerve until the original resting potential of minus 70 MV is achieved. The entire process requires 1 millisecond. That is, for depolarization, it is 0.3 milliseconds, and for repolarization, it's a sequence of events that leads to the nerve conduction. It mainly depends on two factors, that is the concentration of electrolytes in the exoplasm and extracellular fluids. And second is the permeability of the nerve membrane to sodium and potassium ions. In a resting state, the nerve membrane is relatively impermeable to sodium ions and it's freely permeable to potassium ions. It is impermeable to sodium ions. It's to prevent a massive influx. The ions are potassium and chloride. After repolarization, the action potential terminates when membrane repolarizes, causing an inactivation of the increased permeability of sodium. Thus, there is an increased permeability of potassium into the nerve membrane, and this efflux of potassium leads to the repolarization of the nerve membrane. Thus, the movement of potassium out of the cell is in depolarization. A slight excess of sodium exists within neuron and potassium extracellular. It is due to the metabolic activity that initiates active transfer of sodium ions out of the cell via the sodium pump. The energy needed for this is taken from against the concentration gradient. This energy comes from the oxidative metabolism of ATP. The same pumping mechanism activates the transport of potassium ions into cell against concentration gradient. Complete transfer of impulses. There is the first is the resting membrane potential, then there is repolarization, followed by repolarization and back to the resting membrane potential. Now there are two different points that we have to know. That is the absolute refractive period. In this, it's the inability of a neuron to respond to another stimuli for a time period after the initiation of an action potential, regardless its strength. And relative refractory period is defined as an impulse can be initiated only by a stronger than normal stimulus and its continued to decrease under Impulse propagation. It's the transfer of impulse from one nerve ending to the other nerve. It's followed by concentric depolarization and repolarization across the nerve fibers. And in this, we can see the gradual transfer of an impulse from the cell body to its dendritic ends around the axon, and then it is transferred to the next nerve body. Now, there are two types of nerves. There's a myelinated and an unmyelinated nerve. The difference is the presence of a thick myelin sheath in myelinated nerves, and in between there is a nodes of Ranvier. The spread of this impulse differs depending on whether a nerve is myelinated or not. In non-myelinated axons, the impulse moves forward by sequential depolarization of short adjoining membrane segments, while depolarization in myelinated axons, on the other hand, is discontinuous. The impulse leaps forward from node to node. This is known as saltatory conduction and is more rapid in a thicker axon because of the following factors. That is, the thickness of the myelin sheath increases with increasing diameter of the axons, and the distance between adjacent nodes of Ranvier increases with greater axonal diameter. That means, as long as the nerve is thick, the myelin sheath will be thick, and as such, the nodes of Ranvier will be also apart. So the transmission of impulse will be faster. This is known as saltatory conduction. Jumps from node to node where depolarization takes place. Many theories have been proposed over the years to explain the mechanism of action of local anesthetics. There are five main theories. The first is the acetylcholine theory, calcium displacement theory, surface charge theory, membrane expansion theory, and specific receptor theory. Acetylcholine theory, acetylcholine being a neurotransmitter, it was found to involved in nerve conduction. But there are no evidences present. The calcium displacement theory states that nerve block is produced by the displacement of calcium from some membrane site that controls permeability to sodium, meaning the concentration of calcium ions that does not affect local anesthetic potential has diminished the credibility. The surface charge or repulsion theory it explains that local anesthetics act by binding to the nerve membrane and changing the electrical potential at the membrane surface. The membrane expansion theory, it says that the LA penetrates the hydrophobic region of the nerve membrane, decreasing the diameter of sodium channels, leading to inhibition of sodium conduction and neural excitation. Now, the last and the most acceptable theory is the specific receptor theory. It's the most favored one, and it proposed LA act by binding to specific receptors on the sodium channel. Specific receptor sites for LA exist in the sodium channels either on its external surface or on the internal axonic surface. Based on this, the local anesthetics are classified on the biological sites. That is, the LA molecules that it is on the receptor site on the external surface. Second is that attacks on the inner surface, independent action. And the fourth classification is that it is the receptor mediated and independent, both actions are present. This is the classification. It is based on the biological site and mode of action. Coming to LA definition, local anesthetic is defined as the loss of sensations as a circumscribed area of the body caused by depression of excitation in the nerve ending or inhibition of conduction process in the peripheral nerves. The properties of LA. Ideal properties should be like it should not be irritating to tissues to which it is applied. It should not cause any permanent alteration of nerve structure. Systemic toxicity should be low. It should be effective regardless of it is injected or locally applied to the mucous membrane. Time of onset of anesthesia should be as short as possible, and duration action should be as long as enough to permit completion of the procedure, yet not so long as to require an extended recovery. It should have potency sufficient to give a complete anesthesia without the use of harmful concentrated solution, should be relatively free from producing allergic reactions, should be stable in solution and should readily undergo biotransformation in body. It should be sterile or capable of being sterilized by heat without deterioration. The mechanism of action is described as displacement of calcium ions from the sodium channel receptor side. This binding of La molecules to the receptor side, and there is blockade of the sodium channel, which eventually results in decreased sodium conductance, and there is depression in the rate of electrical depolarization, leading to failure to achieve the threshold potential. There is lack of propagated action potential, and thus causes conduction blockade. Such a blockade is defined as a non-depolarizing nerve block. Dissociation of La. It is described by the Henderson-Hasselbalch equation of pH is equal to pKa plus log base by acid. That's the amount of local anesthetic available for action across a nerve membrane. The local anesthetics are tertiary amines, that is weak base, and they are poorly soluble and unstable in air. Thus, they are dispensed into acidic salts, that is hydrochloride salts, to make it stable. Local anesthetic salt, that is RnHCl, is dissolved in saline or sterile water and it exists as base, that is Rn, and as cations, RnH+. In lower pH, that is more of hydroxyl, most of the anesthetic solution exists in its cation form, that is RnH+, and in higher pH, this is less of hydroxyl, most of the anesthetic solution exists in free base form. Now, the base form is the one that dissolves across the nerve membrane. So, if it is lower pH, the anesthetic solution that can dissolve across the membrane will be less. Now, the action of LA on an infected tissue. Let us take 1,000 molecules of local anesthetic is deposited in a tissue which is infected and inflamed and has a pH of 6. So, the pH of the surrounding area is lesser. So, the more of the ions will be present in RnH plus form. At this low pH, there 990 molecules of RnH plus, that is 99% of the molecules are in the RnH plus form and only 10% are available in the Rn form. So, only this 10% Rn form will diffuse across the membrane, of which 75% gets converted to the RnH plus and 25 remains unchanged. This RnH plus molecules bind to the receptor sites within the sodium channel, resulting in blockade. Effectively, of the 1,000 molecules injected, only 7.5 molecules are available for attaching to the receptor sites within the sodium channels, causing blockade. This is the case scenario in an infected tissue. Now, the factors affecting local anesthetic actions are pKa, that is the dissociation constant, as we have explained. It affects the onset of action. Lipid solubility, that is high increase in the lipid solubility increases the potential of the local anesthetic. Protein binding, that affects the duration of the action of LA. And the increased protein binding allows the anesthetic cations to firmly attach to the protein in receptor site, and thus prolonging its duration. Vasodilator activity, it causes the anesthetic potency and duration. When there is greater vasodilator activity, there is increased blood flow to the region and more rapid removal of the anesthetic molecules from anesthetic site, injection site occurs. Thus, the duration is decreased. So, the vasodilator activity is prevented. Thus, the vasoconstrictor is added. Non-nervous tissue diffusibility. It directly acts on the onset of action. And if there is increased diffusibility, there is a decreased time of onset. Induction of LA. Yeah, when a local anesthetic is injected, as we have already explained, the local anesthetic is diffused into the nerve membrane. So only when the core fibers or the core bundles are wetted by the local anesthetic, the anesthesia of the nerve occurs. Only the mantle fibers or the peripheral fibers are only wetted. The anesthesia will not be performed. Now, in a case of re-injection of LA, when the local anesthetic effect is re-diminishing or it has already diminished, we go for a re-injection. Now, there are three case scenarios that can exist when such a situation occurs. That is, there is a recurrence of immediate profound anesthesia. Once we inject the LA, the patient gets a profound anesthesia. Second is a difficulty in re-achieving the profound anesthesia. Patient doesn't get anesthetized following the re-injection. And third is the tachyphylaxis. That is a profound reaction against the local anesthetic agent. Patient may experience shortness of breath or allergic reaction against the local anesthetic agent. These are my references. Thank you.